Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the channel. Today we will talk about a university short essay question regarding a disease in the external auditory canal. We will try to diagnose and treat the provided case. Let's see what the statement tells us about this particular patient. So this is a 35 years old female which came to the ENT outpatient clinic with complaints of severe pain in right ear for the last 2 days. She told that the pain was so severe that she could not sleep last night. So there is severe otalgia, and this is from last 2 days. And she had a sleepless night. So that shows the severity of the pain. And because it is from last 2 days, so it means that automatically all those diseases, chronic diseases which can cause earache, they are ruled out. Because we know that clinically any symptom which is there from last 3 weeks or less than 3 weeks, the disease is acute. So we have to concentrate only on acute diseases causing unilateral earache. Then another information which was provided in the history, that this pain increased during chewing and eating meals. So we know that the movement of the jaw increase the pain whenever there is pathology, acute pathology there in the external auditory canal. So it means this particular lady is having some acute problem which is there in the external auditory canal. And this statement seconds our provisional opinion that the problem is there in the external auditory canal, because there is no complaint of ear discharge or hearing loss, because we know that whenever middle ear is involved, usually there will be ear discharge and definitely there will be hearing loss. While in case of external auditory canal, still it will be having a severe otalgia, but still there may not be any hearing loss. So it means that this particular lady is having acute problem in the external auditory canal. She had a habit of scratching her ear with hair pins and matchstick. She also used to clean her ears with cotton buds, especially after taking bath. So she is habitual ear scratcher, so that there is every chance of that she is traumatizing her external auditory canal, and any small abrasion or laceration there, especially after use of this hairpin or matchstick, the bacteria have every chance to get into and cause the infection. So from this whole information, we come to the conclusion that this particular lady is having acute otitis externa. And as we know, these were the questions which were being asked. So we will try to answer these questions one by one. And first one is, of course, is about the most probable diagnosis. So just we analyze the statement, and from the analysis of this statement, we have come to the conclusion that this particular lady is having a problem which is acute, and it is involving the external auditory canal, especially after some kind of trauma by cleansing or scratching with the hairpins or matchstick. So this particular lady may be having acute otitis externa. And as we know, acute otitis externa, it is of two types. Either it is localized or it is diffused. So localized one, we know it as furunculosis also, which is the Staph aureus infection of the hair follicles. And it may be a diffused type of otitis externa, in which the skin of whole of the external auditory canal is inflamed. And the clinical features of furunculosis, we know there is otalgia, as in this particular case is jaw movements painful. Yes, same is the case here, because the pain is aggravated on chewing and eating meals. There, on examination, we will see the swelling of the external auditory canal, which will be confined to the cartilaginous portion, which is having hair follicles only. Then there will be tenderness and tragal sign will be positive. And on otoscopy, if we are able to see the tympanic membrane, if the size of the boil, or in case of diffuse otitis externa, the inflamed external auditory canal walls allow us to examine the eardrum or the tympanic membrane, it will be normal because middle ear is okay in this case. And then regional nodes may be enlarged and tender, and post-auricular sulcus is obliterated in case of furunculosis as compared to acute mastoiditis. In acute diffuse otitis externa, usually it starts with heart burning in the ear, followed by severe pain, which is aggravated by jaw movements again, and then ears may start oozing, followed by serous discharge, and later it becomes thick and purulent as the infection spreads, and pinna movements are always painful. There is edema and obstruction of the external auditory canal with lymphadenopathy and cellulitis of the surrounding tissues. So what is the differential diagnosis in this case? Of course, first of all, because there is a history of scratching with sharp objects, so ear canal trauma. Then there can be wax impaction, cerumen impaction, because that wax, it can be pushed inwards due to the usage of those cotton buds. Then there can be laryngitis bullosa hemorrhagica, but in this case there will be pseudosanguinous ear discharge, and the tympanic membrane will be having reddish blebs or vesicles. Acute otitis media. In acute otitis media, if it is there at the pre-suppuration stage, the tympanic membrane will be congested and there may be cartwheel appearance of the tympanic membrane, but in such cases it is usually preceded by upper respiratory tract infection, which is not mentioned in this particular case. Malignant otitis externa, these patients are usually old age and they are diabetic as well, and there are granulations in the external auditory canal, and even the cranial nerves may be involved in later stages, but there the pain usually comes later. Foreign body ear, and then there can be Raffled Otalgia, but in case of Raffled Otalgia, the examination of the ear should be normal. And then ear canal carcinoma to complete this list. What do you expect on otoscopy? This is the next question. So in this particular case, as I told you, while it should be visible there in the cartilaginous portion of the external auditory canal, because while we know it is a Staph aureus infection of the hair follicle, which are confined to the outer 1/3 of the external auditory canal. And in case of acute diffuse otitis externa, of course, there will be inflamed and congested external auditory canal with some discharge. Tympanic membrane, it may not be visible due to the size of the boil, one. Secondly, if in case of diffuse otitis externa, the whole of the external auditory canal inflamed and lumen may be very narrow. And thirdly, because of the acute nature of the disease, otoscopy may be very painful for the patient and patient may not be cooperative. But even then, if we are able to see the tympanic membrane, we should expect a normal tympanic membrane in this particular case. Treatment plan. In early stages of the boil, when abscess has not been formed, we have to go for antibiotic, which are effective against Staph aureus. Patient is in severe pain, so we may need injectable, strong, potent analgesia. Then hot compression, and if some discharge is there in case of diffuse otitis externa, we have to remove that. And then we can pack the external auditory canal with 10% ichthymol glycerine. This ichthymol glycerine, it has got specifically anti-staphylococcal qualities, and at the same time it is hygroscopic, so it will relieve the pain by reducing the edema of the external auditory canal. Instead of 10% ichthymol glycerine, we can use medicated wick, which are having antibiotic plus steroids, and we can pack the external auditory canal, and these wicks should be replaced after 24 hours. So they will act as a stent in the external auditory canal. They will reduce the edema as well, and indirectly reducing the pain as well. But if abscess has been formed, then of course we have to go for incision and drainage. What are the predisposing factors of this disease? There are so many predisposing factors. Two factors were mentioned in this case as well. One was this scratching with hairpin and matchsticks, and second was trying to clean with the use of these cotton buds. Hot and humid weather is also a predisposing factor. Diabetes and in immunocompromised patients, they are more prone to get infections than if patient is allergic, or sometimes it is associated with chronic suppurative otitis media. In case of chronic suppurative otitis media, the ear discharge which is coming from the external auditory canal, it is soiling the walls of the external auditory canal, leading to diffuse type of otitis externa, or the patient may become allergic to the ear drops which are primarily used for the treatment of chronic suppurative otitis media. Then certain patients, they have congenitally inherited, they have narrow ear canals which are more hairy, and they may also be having a non-atopic type of eczema which is involving the skin of the external auditory canal as well. So our advice to the patient will be, yes, she should avoid scratching of the ear canal, because I told you even a minor scratch, small abrasion is sufficient to invite the bacteria to penetrate and cause the infection. Then in general, we should convey our message to the public that they should relinquish the use of Q-tips, which are commercially available cotton buds, because when they are using these cotton buds, they want to clean the wax, but instead of that, they are pushing the wax deep inside, and it becomes hard and obstruct the ear canal. Because there is a natural self-cleansing system in the external auditory canal, we know that the squamous epithelium anywhere in the body, rest of the body, superficial layers are being shed off continuously, and these are being shed off towards the surface. But the skin of the external auditory canal, it has a special peculiarity in the sense that it travels towards the introitus, or the opening of the external auditory canal, from the center of the tympanic membrane, because the outer layer of the tympanic membrane is also squamous epithelium. So from center of the tympanic membrane, this shed of epithelium, it travels towards the periphery of the tympanic membrane. From there, along the walls of the external auditory canal, this shed of epithelium migrates towards the introitus, or the opening of the external auditory canal, from where it is being shed off whenever we chew, whenever we yawn, whenever we swallow, whenever we do jaw movements, it is being continuously shed off. But if we are using these cotton buds or Q-tips, or we are in habit of scratching the ear canal, we are hampering the migration of this epithelium, so that it becomes collected there deep in the deep meatus, and leading on to the obstruction of the external auditory canal. Secondly, wax is a normal secretion. It is not an abnormal secretion, because it has got an acidic pH, so it is hostile for the bacteria, and it is also repellent for the germs, and it is oily in nature, so it does not allow the water to stay there in the external auditory canal. So we should not hamper or interfere the migration of this epithelium. Last question was that what is the cause of Raffled Otalgia and the nerve responsible for this Raffled pain. We know that Otalgia is the sensation of the pain in the ear, while Raffled Otalgia or Raffled pain anywhere is the pain which is felt in that particular area, but it is originating from some other areas where the same nerve is supplying the area. For example, in case of ear, we know that there are 4 cranial nerves and 2 cervical nerves which are supplying the ear, as well as many other areas in head, neck, thorax and abdomen. So pain can be referred to the ear, actually is originating in the areas which are far from the ear. So neoplastic, infectious, inflammatory, musculoskeletal and vascular disorders should all be considered in evaluating a patient with otalgia, but a normal ear examination. Because a normal ear examination means that there is no primary cause of that earache, rather it is going to be a referred otalgia. So otalgia is frequently presenting complaint in patients with carcinoma of the oropharynx or the hypopharynx. The nerves, as I told you, there are 4 cranial nerves which are supplying the ear. One is this posterior auricular nerve, which is a branch of 7th cranial nerve, facial nerve. Then there is auriculotemporal nerve, which is a branch of trigeminal nerve. Then there is Jacobson's nerve, a branch of glossopharyngeal nerve. Arnold's nerve is a branch of vagus nerve. And then there are cervical spinal nerves C2 and C3. So the pathologies occurring in the neural network of these cranial nerves, number 5, 7, 9 and 10, and cervical spinal nerves C2 and 3, can be considered as possible etiologies of referred otalgia. Children usually suffer from primary otalgia, that there is some ear disease which is causing a earache in children, while adults usually suffer from referred otalgia. Especially in old age patients, there may be a carcinoma of the larynx or hypopharynx or oropharynx in which the pain may be referred to the ear. In one study, the most common etiology of referred otalgia was the dental pathologies, accounting for 50% of the cases. In another study, they saw 33% of the patients suffering from carcinoma of the base of the tongue, they were having this referred otalgia. So the answer for this question will be that oropharyngeal pathologies like tonsillitis, quinsy, CA base of tongue, post-tonsillectomy patients in which the glossopharyngeal nerve is involved, they are usually having referred otalgia. Then laryngeal and hypopharyngeal lesions, the 10th cranial nerve is involved there, and the dental pathologies including caries or infections of the teeth, and then temporomandibular joint dysfunction. It is usually the auriculotemporal nerve, which is a branch of trigeminal nerve, 5th cranial nerve is involved. Then cervical spine pathologies like caries, spondylosis, osteoarthritis, any disease which can involve the cervical spine, the pain can be referred to the ipsilateral ear, and the spinal nerves involved here are C2 and C3. And then in case of vestibular schwannoma, or in case of herpes zoster or Bell's palsy, in which the ear examination is absolutely normal, but still the patient is having a pain in the ear, and there this 7th cranial nerve is involved. So these are the 4 cranial nerves and 2 spinal nerves, and the areas which they are supplying in addition to ear, the pathology actually may be there in those areas, and the patient may be feeling earache, and that's what we call as referred otalgia. So if you think that it was beneficial for you, you please subscribe and like and share the channel, and thank you very much for watching.